Okay. Thank you so
Well,
much.
thank you very much, Claire. Claire, so who is the foster? Are you the foster or am I the foster? I mean, I know that our parents knew each other way back when, from we were little tiny tots. And you became a doctor, I became a doctor, just slightly different types of doctors. You were always the actress and the entertainer, and I was always the serious one. Anyway, little sister, you're so fussy. You give those poor elected officials such a hard time. You're holding their foot to the fire. Good for you. Anyway, as a doctor, since Francine, you didn't introduce me, I'll tell a little bit about myself. I am a physician, Yale trained, with a master's in public health. I did a public health degree because I thought by now we would have had a universal national healthcare delivery system in the United States, and always wanted to be part of the administration of things. I thought that public health degree would have helped me. I went to Cuba in 1980 as I was doing my public health degree, studied the Cuban health system, came back, couldn't talk about it. So I basically subsequently studied the United States healthcare delivery system. I've been in practice for more than some years. Uh, I think it's definitely more than 30 years. And I practice in Brooklyn. Now, you know, Brooklyn is always in the house. No matter where you go, there's Brooklyn in the house because it's probably our most populous county in the country. So when you come from Brooklyn, people will know you, and you will know people who have passed through Brooklyn. So back in when the pandemic started, our Brooklyn congresswoman, and I apologize for noisy Brooklyn, I keep my windows open so that the coronavirus don't stay in my room, but then the ambulances pass by and make a lot of noise. So my congresswoman, Yvette Clarke, called me back in April of 2020, about a month or so into the pandemic, and asked me, she knew that I was involved with public health things, and she said, so help me sort out what's going on here in Brooklyn. So I assembled my team, we call it the team, she called us the team, and we went around Brooklyn looking at hospital systems. We looked at the various delivery systems and came to a certain conclusion by the end of May 31st. And the conclusion was that we were doing a lousy job in Brooklyn. Not only were we, the healthcare professionals, doing a lousy job, many had just run away and hid from the pandemic, but the leaders, the elected officials, were not doing a good job in Brooklyn. We didn't think we were utilizing our resources appropriately. And we were bringing in a lot of unnecessary things. Like, as you know, our governor had a ship off of Manhattan that was useless. They took our big, the Javits Center, and filled it with beds, empty beds. And our hospitals weren't utilized appropriately. Our human resources weren't utilized appropriately. And it continued. So after we looked at Brooklyn, we looked at the United States, and we came to the same conclusion. So, but this is not about what happened. This is about the future. What is the future of medicine after COVID? So when COVID descended on the population of the United States back in 2020, at that time, the relationships between doctors and patients, that was already strained. The majority of doctors by then had become employees of hospitals or large groups. They were tied to their employers by contract, which, although the doctors were remunerated handsomely, there was usually inadequate psychic income. I'm referring to that other part of why you do what you do, other than the money. You know, I get up and go to work because I feel good about it. That wasn't good. Medicine had to really become bad for doctors. Burnout was high at the time. Low reimbursement for outpatient encounters. An encounter is a visit, right? And if the doctors aren't in control of that, then it was the employers who were in control of that. But the low reimbursement caused the employers to basically create a lot of visits. If you're getting a small amount of money for each visit, then the only way you can make ends meet is to have a lot of them. So physicians, even though they were seeing patients frequently at a high rate, the face-to-face time was minimal. You know, those little drive-in 5-minute visits didn't work for most people. It certainly didn't work for me as a physician. This whole paradigm, when you came in, the doctor would order everything that they can order so that the employer could make all this money. You got all these things done to you, but you never got any face-to-face time or any serious discussion of your problems. Well, all this was upended when a respiratory contagious disease descended upon us, and all of a sudden you can't keep coming in, and if you come in, we can't get close to you. And that is what happened in March of 2020. Fortunately, telemedicine came to the rescue. Telemedicine is where we do like what we're doing now. This is something, so we did medicine that way. The problem with telemedicine is I can't draw blood on you every time you come. I can't do an EKG or a spirometry every time you walk in because you're virtual and I can't do anything. So all I can do is talk to you. Of course, the good news was that we were reimbursed appropriately for telemedicine, and that continued. This substitution, though, of telehealth was just not adequate because, you know, some of us are touchy-feely, doctors and patients, and we valued that close interaction, which could not occur with telehealth. As the pandemic declined, most businesses, and I refer to as healthcare as a business, most businesses decided we should return to what we were doing. The hospitals generating all these highly expensive procedures, these MRIs, these C-sections that they do, often unnecessarily, all these procedures, these surgical procedures that weren't necessary, we thought we would get back to that. But guess what? Patients and doctors recognize that, you know, we don't really always need to get together. We can take care of business sometimes with this virtual thing. It's not always that we could do that, but sometimes it makes sense. Well, this new time will necessitate a new paradigm for outpatient care. It is unclear how we'll reestablish the good old doctor-patient relationship. It's not clear how we'll get back to that in this new millennium. I'll take you back 100 years. Just before 1918, in that 20 years before 1918 influenza pandemic, medicine had gone through a similar major change. It was spurred on by the American Medical Association and the Flexner Report. The Flexner Report says there were a lot of doctors doing nothing. There were a lot of medical schools training idiots. Let's get rid of some of these poor medical schools. Let's not have so many incompetent doctors. Let's tidy up the place. Of course, in the process of cleaning up, a lot of times you sweep out the good stuff. A lot of the black medical schools disappeared at that time, but so did a lot of the white medical schools. A lot of the poor ones did. And so, you know, we were going through this change, and then came this pandemic in 1918, the so-called Spanish flu, even though it wasn't from Spain. It started in America. It started maybe in Europe, but it certainly didn't start in Spain. So the pandemic then gave direction to that change that was occurring. And in the ensuing 10 to 20 years, we saw a major change in medicine. As a matter of fact, the whole 20th century saw a major revolution in medicine, which was spurred on by that major earth-shaking change of the 1918 influenza pandemic. Well, we're in the same situation right now. Just before this pandemic came, we were in a situation where we saw the transformation of the way we did, the way we created our records, the electronic health records. We saw where the good old Marcus Welby type doctor was replaced by the avatar doctor with all the fancy equipment and instruments. The stethoscope here became kind of useless. I just keep this for show, I'm a doctor if I put it around my neck. But, the doctors don't use that anymore. We use ultrasound. We use we use rays, we use, we draw blood, we stick a catheter and swabs into noses, and we send it off for sophisticated DNA analysis. So that's how medicine is actually practiced today. So then as we're doing all of this and creating this medical industrial complex that's just bleeding everybody to death and running the country into poverty, then comes this pandemic. Guess what? All that stuff couldn't work anymore. It couldn't work anymore because, this is real disease. It wasn't that bad a disease. It wasn't Ebola, and people weren't going to die at the same rate, but people were dying, and we saw people die in New York City. We're now in a situation where, the first thing that happened is the government got rid of what was a multi-payer, profit-driven system for the management of COVID. We couldn't do it that way. We couldn't basically ask everybody who showed up with a fever, do you have insurance? And if you don't have insurance, you wait over there, because you couldn't. You would spread disease. So the government recognized very early that, everybody needs to be covered. Universal health care, right? So of course, everybody got covered just overnight. So we went from a multi-payer system immediately to a single-payer system for the management of COVID. Then when the vaccine came, you couldn't send the person to the pharmacy and say, well, if you don't have insurance, then you're not going to get the vaccine. Everybody got the vaccine, regardless of what their insurance status was. So we went to a single payer, universal, meaning everybody got covered all at the same time. So what existed as we went into COVID was an inefficient, ineffective, expensive healthcare system that was also unjust. And that's what brings us to Juneteenth. The fact that you pay for everything, the fact that everything is covered, doesn't make it just. It was unjust before we went into COVID, and it was unjust during COVID, and it is still unjust. But we have the opportunity. This will be the second the second emancipation, right? The first emancipation in 1862, 63, 64, 1865, ended up with a reconstruction and a whole change in the society. Well, we're back there now. We are at the dawning of a new, emancipation. So Marcus Garvey, and I heard you say that earlier, Claire, said, we are going to emancipate ourselves from mental slavery. For though others may free the body, none but ourselves can free the mind. Of course, Bob Marley took it on and sang about it and brought those words to us. So, again, emancipation, you can't talk about that in America without talking about good old Abraham Lincoln. This is ascribed to him. Maybe he didn't say it, but he repeated it. You can fool some of the people all the time. And you can fool all the people some of the time, but you can't fool all the people all the time. So I'd like to take a pause here and, have a conversation from this point on.
Thank you, Dr. Moore. I appreciate the comments that you brought forth today, because let me tell you what I'm hearing. I'm hearing a couple of things with regard to the future. It's sounding like that you're talking about some sort of hybrid telemedicine in-person situation. Okay. And that's one thing I thought that I heard you bring forth. And the next thing I heard you talk about with regard to the future of health and healthcare management is the all the no more thing around your neck, right? No more stuff around your neck. Now it's something that's handheld that the person hold. So with the advancement of right there you go. With the advancement of technology, there is room for what? We want to have more precision, less financial burden, more interventions as opposed to treatments. Is our AI to the point where we can predict that, there is diabetes lingering or perpetuating itself in this household? Can we get into this household and teach proper nutrition? Can we help this household and the community redirect their thinking about nutrition and nutritious foods? Can we bring nutritious foods to the community economically? Whole Foods is supposed to be the pillar of great food, and unless you have no kids, you can't shop at Whole Foods. At least I can't. I don't know about you, but so I'm just trying to say that we present some resolutions. We need to make sure that they are obtainable for the communities that we're identifying. So those are some of my thoughts as a response to you're bringing forth about the information on the pandemic and its effects. One thing I think is very important, and I just so love the theme this year that we're carrying, and it's standing in our legacy to reignite our future. And I started thinking, our legacy is kind of, especially when it comes to healthcare, that's why standing in our legacy, even though you may not have found it important to go back and tell us a little bit of history about the pandemic and its impact, but it is important, because if you don't know what has happened, you don't know what you need to fix. So we talked about hybrid telemedicine situations. We're looking at technology and the impact that it can have. I do so wish that we had an elected official to be a part of this dialogue today. But the important thing about it is that we are having the dialogue. And is my intention there were a couple of elected officials whose portfolio is indeed health. So we'll get a chance to bring this conversation to them and have some response, and we could probably carry on. So I'm really happy about that. So I'd also like to, the multi-payer, the money, follow the money. That's what I'm learning. The multi-payer system and how it was socially important for the government to make the testing available to those who are insured and those who are not insured. It was essential for the government to make vaccines available to those who are insured and those who are not insured to really bring down this pandemic. This morning, I was very pleased to hear some conversation about the United States State Department had a chance to report about how well that they did with regard to the region, because we are domestic today, but we do always have a connection to our families and friends in the region. And from my estimation, it seems as though the United States did a very good job, and we're just hoping that we can continue with that, and not only with that per se, but as we're defining through these social determinants of health, how we can better support positive outcomes or positive health outcomes in key communities, and also how it extends into the region. So we got a lot to talk about. And this part of today, we're going to be domestic, and later on in the week, we'll talk more about the regional impact. So, Dr. Moore, thank you for your comments. I'd like to bring forward Miss Lorraine Mitchell, who is also a friend to ICS. We can always count on her. Her passion is mental health. Her thing is mental health. Her practice is mental health. She's been able to combine it with a telemedicine aspect. I'd like her to come and talk a little bit about, well, we know part of the fallout of the pandemic was the increase of not only the pandemic, but any major, how should we say, event, community-wide event, always brings upon a mental health response. And in this situation where you had so many people were affected with, isolation, loneliness, depression, those type of things, I want to hear, if you can, thank you, bring forth some message to us today and kind of think that this message will be also brought to our elected officials. So when they start talking policy and writing policy, we want to make sure that they hear some of the comments that we have to have, or what that we're having now. Thank you, Lorraine.
Thank you, Francine. Thank you for having me.
My pleasure.
Dr. Moore kind of entered a lot of it's like the prerequisites of what I would have said. So thank you, Dr. Moore, for covering a lot of the bases. But absolutely, COVID-19 kind of showed us that, there were some situations, as Dr. Moore talked about, in our health system, but more so in how we delivered services. And of course, I don't think there's anyone that can say that they've not been touched emotionally and have been left feeling stressed, anxious, or depressed in any which way, even for professionals. So we talk about the regular person on the street, to the professional, the doctors, the mental health providers, individuals who work even at home, or students. We talk about that. For every one of us who provide services in mental health, whether we're clinicians or we're psychiatrists or psychologists, we have seen a spike in folks coming to us, requiring our services. And I'm for myself, I can say it's primarily for anxiety, stress, family relationships, and that stem from, of course, being stuck together for a long time or being absent. So it's two part. Those who lost their family as well. There are many family units who have lost several family members. So you also see that pattern of grieving, and so it's great that we had that component to add the telemedicine. For, of course, we couldn't see each other, and so now with all these changes, it still continues. There are some changes, of course, for our patients. There is a time when patients didn't have to pay that copay, and now we can see across each state that there's some insurance companies that are requiring patients to do copays for the mental health aspects of things. And I can say that from my private practice in itself. But that is not preventing patients from seeking services. What I can say for telehealth is that it has opened up for those who would not have sought mental health services. It has opened up an avenue for those folks to be seeking services because they really don't have to travel to an office, be on a waiting list for services. They can actually be in touch with someone like myself who look like them, sound like them, who's from the Caribbean. And that's what makes it so absolutely great that the telehealth is also breaking down the stigma for mental health services. It is also coupling together the medical component. So, for example, someone like myself, when I see a patient, on the platforms that I see patients on, I'm able to also refer them to a doctor or refer them to a psychiatrist. And I think that is important, or to a nutritionist. So we're able to kind of combine these services together. And for those of us who are trained in those kind of holistic way of supporting our patients, it's really wonderful. We're able to do those referral in-house and know that our patients are completely served. So we probably wouldn't have been able to do that on a face-to-face level, but the patient is able to go to a Dr. Moore, or then to see a nutritionist, and then to get all those services combined through that telehealth. And for a patient who may be an administrator in a very high position, they don't have the time to go to all these places physically, but they can certainly do it through the telehealth part of it. So that's one absolutely benefit of that I hope will continue for our patients. The other part is that I'm also part of the Northeast Diaspora as one of the co-chair, but the co-chair that covers mental health as well. And I'm actually sitting in Jamaica right now. We just had our Jamaica Diaspora, sorry guys, sitting in Jamaica. But we just had our Jamaica Diaspora Conference, and that was one of the conversations that we had here in Kingston with the Ministry of Health and the Ministry of Foreign Affairs about telehealth. And we were able to actually demonstrate and speak about the work that I myself we have done, along with fellow colleagues over the duration of COVID, where we were able to support individuals who are in Jamaica while I was in the US. For example, our patients who with cancer, I was able to provide services to them, supports to them. So telehealth is here, and it's showing us that boundary limitless way in which we can support, in which we can educate, in which we can be there across. Not just at home, but also in the region. It's proven. We have also been a part, as the diaspora, as part of a project through the University of the West Indies called the Life Project. And while we were here, we were able to also use telehealth as a psychoeducation for those patients. It's a program that looks at non-communicable diseases such as diabetes and heart disease, which is one of the number one killer in Jamaica. And we were able to provide that psychoeducation to our patients without physically being with them. So that telehealth is also showing us the way in which we can educate, not just our patients, but also we have used it to educate also providers. What we're hoping to do, and I definitely would like to push that, is that we're able to also, as we're seeing that providers are stressed as well, and probably Dr. Moore can really align with that, because I think you touched on that, the stressful nature in which we work. And so we want to be able to use that telehealth to provide that support so that we don't have the burnout. There's a high burnout rate amongst us as providers. The therapist need a therapist, the doctor needs a therapist. So we want to be there to provide that support, and we can absolutely do that through using telehealth. So how do we continue to do that? It has to be a push. I believe the push is here, where we're saying the hybrid nature in which we do business. I think it's going to continue. Maybe the payable part of it, there would be some adjustment, but I believe hybrid is here to stay because it works. It was working before in other areas. For example, one side of my company provides support to individuals with cognitive disabilities. And all of my staff have worked for the last 8 years at home. So we know it worked. So it's just a matter of seeing it work within medicine and mental health, and having it being coupled together, and then putting in the different systems that would ensure that our patients are covered. There's the liability, there's the HIPAA compliance, and all that needs to be. And it's already been done. And that anyone who's using telemedicine is also trained, because it's not the same as face-to-face. So it's also the training that comes with it. I also teach here in Jamaica. I teach multicultural counseling class. So I've also used that component in how do you work with someone across the board who is not sitting in the classroom with you, using that Zoom or whatever platform we use, but also having that concept of that student, maybe someone who graduates and work with someone else in another country, maybe in a Caribbean island. So we are using it in the education, in the support of our patients, and also in the support of our providers.
Thank you, Lorraine. I was thinking while you were speaking about, the way telemedicine is being used, and it is. My thought was along the lines of the technology. Now, okay, there was telemedicine going on before the pandemic. The pandemic showed us that we had to rely more on telemedicine and and virtual situations. Are there any innovations that you could think of that might be helpful in a telemedicine or telehealth situation? Because we would like to be able to say telemedicine and hybrid situations or full telemedicine works. And guess what else we can do with it? Is there an and for you?
There is always an and, especially
I know,
right? When it comes to people's life, it's not one size fits all. And that's why I said there's training, there's initial training, and there has to be continuous training. So when you think of a person sitting across from you, you can always be innovative according as to your patient. But when you think of a person not sitting across from you, especially for myself, I work with children. And so, a child begins to get bored after about 15 minutes. So how do you keep a child engaged when it's virtual? And the parents will ask for virtual because of different reasons, and you accommodate that. But you have to be innovative. The platforms that we use, I don't have to necessarily speak of all of them, but I know we use Zoom. There is a Zoom medical part of it, not the regular Zoom that we all use, but Zoom has a component for those of us who are professionals, medical professionals, that has a different, and I guess a higher level of compliancy. And then there are other platforms that use specific. You can't go through any other platforms, but theirs that are protected. They have to be compliance protected. Excuse me. And so how do you become innovative with that? I think that depends on your experience as a clinician or as a provider, but also understanding your patient that's sitting across from you, understanding your delivery, and being comfortable with the method in which you're using. Also, the broad width, I hope I'm saying it correctly because I'm not
bandwidth. Yes.
Yeah. Sometimes that can cause some issues, but I believe as we've moved forward, that all our countries will be looking at increasing that, so that there will be no glitch in terms of how we communicate. Like we're communicating now, and I'm sitting in other countries. It's great. So that's one component. But also, I believe eventually insurance companies has to give us this leeway. We're able to provide services, in different regions. And maybe that's something that we as providers can sit at the table and say, you know, if I'm licensed in this state and I'm licensed in this country, because you can be licensed in several different places, how can we provide supports to our patients? So I think those are some of the things that we can continue to have conversations about. But the innovation comes with the experience that you may
Yes.
have, the situation that you're seeing that client about or that patient about, and how you as the provider deliver yourself.
Okay. Well, thank you so much, Lorraine, Dr. Lorraine Mitchell, to be bestowed, and Dr. Donald Moore. Thank you both for your comments. Um, you know, part of this year we're only looking at three aspects of our recommendations to the State Department, and the three that we're looking at coincidentally are telemedicine, telemedicine, um, not only for a domestic agenda but also for a regional agenda. Um, we're also going to be looking at hospitals, hospital management, hospital systems, hospital engineering systems. You know, like making sure that the X-ray machines are still working, and um, what what type of electrical grid do they need to support, and all those type of things. The other thing we're going to be talking about is complementary and integrative medicine, and the development of holistic products. So that's what we have planned for later on this week. I was going to see if Dr. Nelson had any comments about our to our can't see if she's there or not. Anyway, so what we're going to be doing right now is thinking about if we had an elected official here today, what would we want them to leave here to discuss with their colleagues? We have possibly an opportunity to make sure certain topics are discussed. We've already talked about, we know we're going to talk about the hybrid telemedicine. I think we're going to also look at innovation. What do you think?
Absolutely.
I could just add a couple comments to the first part of your question about what does telemedicine bring to the table other than, it could be safe in an infectious situation. Well, one of the things that I'm able to do now with telemedicine, I have let's say a daughter in Texas and a patient in Brooklyn, on the other side of Brooklyn, who would normally take an ambulette at a significant cost to bring that patient into the office for that half an hour visit. If it does not require a significant physical examination, I can have the daughter in Texas join the meeting, the son in California, and the patient who is with a home attendant. And so the group of us are in the conversation. So it saves time and costs all around. Another good example where it works is I can see, when sometimes a patient will come into a telehealth visit with a virtual background. I said, no, I want to see where you are. I want to see your environment. I don't often see that. They see my environment when they come here. But as a doctor who makes house calls quite frequently, I know the importance of knowing what environment the individual is in. But what would I want to say? So those are some of the things that I would want to tout about telemedicine being a useful thing just beyond, we don't have to get together and spread germs. One of the things we saw appear during this pandemic is mandates. You spoke earlier about, okay, I spoke about we have the opportunities to expand on what we were doing, the earth-shaking change of a pandemic. Well, we're not just all of a sudden be smarter than the way we were. back 100 years ago, when we had the 1918 influenza pandemic, the kind of things that doctors did then, we look now at and said, gee, I can't believe they believed all of those things and did all of those things. They were doing things like grinding up people's, taking people's saliva, mixing it up and giving it back and say, gee, this is your vaccination. Well, if you recall, we were supposed to end this pandemic with a vaccine.
Yeah.
There is practically no evidence that we did anything with our vaccine other than spend a few $1 trillion and injected people with experimental products. We didn't change much. There is not much difference between the vaccinated populations in other countries versus countries that did not have a lot of vaccination, or even in this country. At the beginning, we said it was going to end the pandemic. When it became apparent that it wasn't going to end the pandemic, we said, well, it's not going to make you sick. You're going to be less sick, or you won't die if you take the vaccine. But at the end of the day, when we did the analysis, it really didn't make much of a difference. Well, it was the same way at the last time. When they looked at all the various things they did in 1918 and they did the analysis, it took them many, many years to learn from what was done. So I'm not saying today we're going to be a lot smarter just because we went through 2 years of hell and we all of a sudden saw the light. No, we're just as ignorant is the correct term about medicine today as we were in 2020. We're just as ignorant about the coronavirus today as we were then. We have lots of information. We know a lot of things, but we basically can't do much about it. Fortunately, the virus has moved on. The virus has gotten a little bit less virulent. The virus, even though our immune systems have sort of learned how to cope with the virus, but we really haven't changed much. So what happens, D.A. Henderson, this was the doctor that was credited with ending smallpox as a scourge worldwide. His feeling after looking at his opinion, after looking at smallpox, how that was eradicated, and the reason why we eradicated smallpox is because there is no animal vector. Once we get rid of it from human beings, it's gone until we bring it back. Well, we can't do that with coronavirus. We can't do that with influenza, because when we don't have it anymore and our immune system has improved, the virus goes and hang out with some birds and then comes back later when our immune system wanes. And our immune system will wane. We don't keep immunity to things that we're not constantly exposed to. So coronavirus is going to be around, just like influenza is going to be around. And, a vaccine that you take 2 years ago, or that was made 2 years ago, doesn't necessarily work today. And that's just a principle of medicine. It's, you don't have to be really smart to understand that. So what our elected officials need to know is that we don't know a lot, and we should stop mandating people to do things we don't even know what the consequence is going to be. So we said that we were going to end the pandemic with the vaccine. When it didn't end, we said, oh, it's those people who didn't take the vaccine. So then we started forcing those people to take the vaccine. Now, if the vaccine really worked that well, then we should be all protected if we took it. But that didn't happen. So it's those people who didn't take it. So then we forced them. When they didn't take it, we fired them. We took them out of their jobs. And now we're all suffering the consequences. We don't have anybody to take care of the patients because we fired the good people, because they thought in their own whatever thinking they had that I don't think I need to take this particular medicine. So I'm going back now to, how does this relate to us in general? There's always been that type of mentality or attitude that we're going to make other people do this and we know what's best for everybody else. We don't. We don't know what's best for everybody else. And when, D.A. Henderson, I get back to him, he says societies that respond to threats like a pandemic or some major calamity in a society, the ones that keep the structures in place and don't overreact do better than those who upend everything. And that's what we did. We shut things down. We stopped children from going to school. We covered everybody's faces. We did all these things, and now we're suffering the consequence, and we had very little impact on the virus, the pandemic, this respiratory virus. So that's one of the messages I think we need to give to the elected officials. Continue to...
So mandates. So the issue is mandates.
Get rid of the mandates.
And perhaps mandates should not necessarily be so blanketed. What do you say? Is that what you're saying?
Well, they shouldn't have been there in the first place. People, what was interesting? In the beginning, the government didn't know whether we should wear masks or not wear masks. So they gave their opinion, which is fine. But then all of a sudden, everybody should wear the mask. Which is it? They went back into 1918 and look, did it make a difference? It didn't seem to make a difference. Has it made a difference? And we really don't know. The taking 2, 3, 4 shots of a messenger RNA vaccine change what is going to happen to the individuals within a population. The evidence is it probably hasn't done that. So yes, I wear my mask, and I wear my mask because it makes sense to me. If there is a virus around there, even though this little thing doesn't stop viruses, I have better masks than this, but I still want to wear it because if you're coughing or I'm coughing, I don't want to spit on people. I look at my computer and I see there's little spit marks on my computer screen. So I know that just talking to you is spurting things out. So it makes sense to me to wear the mask, but it doesn't end the pandemic. And so me mandating it doesn't do anything. It just makes people upset. It makes people unhappy.
Well, I think in all fairness to public health, I think that we make maybe what should be recommendations. We make mandates on information that we gain. Like, for instance, there's a mask study that tells about, respiratory, penetration and such and such and such, and all the different masks that are better, best, and, just a waste of time. So they do have the data. And I really don't think it's a blanket, you got to do this or this. I think it is, like, for instance, I see people, they're in a park with a wide open field and they have a mask on. I'm like, whereas that's their prerogative, the mask would be best suited in an indoor situation where there are other people around them. They could possibly get coming in contact with the coronavirus or any type of influenza virus, cold and cough, whatever.
Yeah.
But so am I going to say I'm going to give that person the freedom to do that? But the information or the education or the best use of it, it's not only going to be one, just mask, just hand washing. I think it's going to be a combination of things that should be available. I think people need to be informed enough to choose what is best for them.
But if I may interrupt, there were federal mandates.
Well, I know the mandate.
There was state mandates for vaccination.
Yes, there were.
And if you look at states that had mandates versus states that didn't have mandates, it was pretty much the same. There were mandates for masking, and it might have made sense when the virus had a high prevalence, but it doesn't necessarily make sense all the time. There were lockdowns that has ruined the economy.
Yes.
You know, so those are the things that elected officials could have done differently had they
So
really looked at the data or
recommend
data.
recommendations versus mandates, more freedom for the individual public to make decisions about the way they manage their um, um, exposure rate or exposure level. Okay. So those are kind of two things. Right. Well, that's a beginning. That's a beginning as we talk about different health and healthcare policy. So we are at the 2 o'clock hour. Let's see.
There's a question here. I'm sure did you answer the question yet?
Okay.
Considering evidence, there should be recommendation rather than mandates. Was that question answered? Considering evidence, should there be a recommendation rather than mandates? Was that answered?
No, let's see.
Well, I'm asking, so Kaina is asking the question, considering evidence, should there be recommendation rather than mandates?
And I will reiterate the point. We don't have evidence that give us enough for mandates. For example, 90% of the people who were vaccinated with an experimental product. The reason why the vaccines are experimental and not licensed is because we don't have the evidence. If we had the evidence, we would have licensed the vaccines. The vaccines are new. Medical treatment takes time to evaluate. There was the studies for the vaccine all vaccines were approved under emergency use authorization. That's not licensing. That's saying, okay, we don't have enough evidence, but we got to get started, so let's use them now. With 2 shots, we've gone way
boosters.
2 shots. We've gone into 4 shots, right? Boosters. There is no medical evidence about boosters. We know that the 2 shots only work somewhere between 4 to 6 months. Because I measure antibodies in my office. I measure the antibodies of all my patients, and the antibodies wane. You know.
After coming here, I'm sorry.
Don't fall in. Yeah.
This is a policy issue that we need to really discuss. Because if we're all monkeys in this zoo of life, right? Okay.
Experimental subjects.
Right. Experimental subjects. Here's what I resent as an educated consumer. We are not given the opportunity to opt in to be educated participants in this study. I resent that because this antibody question, for example, since we're all experiments, shouldn't those of us who have been vaccinated been able to say to our doctors, we've been vaccinated twice, I caught it once, I wanted an antibody study on myself. So if you have 100 million people vaccinated, shouldn't at least maybe 1 million to 10 million people be participants in this zoo of life study?
Well, Dr. Nelson, they don't care. They don't care because they didn't care when they were in Tuskegee what happened. The goal there was not treatment. The goal was experimentation. I want your blood sample to do an experiment. I can't do an experiment on your blood sample, I don't care. How would you feel? Why are we giving treatment, but we're not assessing the treatment? Here, take a vaccine in some supermarket or, all right, pharmacy, and then go away, don't come back. You know?
So how do we advocate? This is very serious because I think we have to advocate. I am not an anti-vaccine person, but right now I'm an anti-booster person because I'm saying your body is supposed to be able to have time to build up antibodies. I don't know what has happened to my body. I've had 2 vaccines. I was forced to have a booster. Why? Because I wanted to go into a building and they say I had to have a booster to go to the building. So I said, Lord, should I? Do you know that the booster was the only one from which I had a fever? I never had a fever before the booster. I took the booster and now I have COVID and hear my voice can't come back on now after COVID in May. No, my question is, nobody has said to me, there's no one can stand up and say, I would like to be in a study to have my antibodies measured now and 6 months from now based on my exposure. As an engineer and educated consumer, I am very frightened and nervous. So now I'm ready to take up arms in the state of Maryland and say, we want to make sure that those of us, if the population of Maryland is 30 million, 10% of Marylanders are subsidized to have all of these quote unquote additional tests done over the next 3 years to see what this vaccine really did.
Yes. Well said.
Does that make sense? Or am I saying stupid?
And that's a point I think we need to share.
It's an NIH study.
So that is going to write down as an action item.
Yeah. And it does not have to be a study. It can be a recommendation. Your doctor should know what antibody level you actually have after, because some people after taking 2 shots have low quantitative levels of the spike virus. Some people take 1 shot and they have a high, so we're all different individuals. If you had COVID back in 2020 and then you take the vaccine, those people have sky high antibodies. And if you even had COVID, you may not even need a vaccine. Why shouldn't I be able to show I had COVID 6 months ago and I've got greater than the maximum you can measure of antibodies? Why do I need to take a vaccine at this time? Oh, exactly. Medicine needs to be a little bit more precise. It can't be just vaccinate everybody.
And because technology is saying personalized medicine is a wave of the future, we have to take sleep and mark death, as we say in Jamaica. This is an opportunity because all kind of things can be manufactured to personalize against people with different things that only belong to different people. Okay? So we have to use this opportunity since everybody was involved in this COVID around the world. And we remember that the Frenchman said, let us take the vaccine in Africa. Even though Africa did not at the time have high levels of COVID, and everybody was in uproar. And the question for me was, why would you say that when in Europe is where it is presenting itself? So that has made me very nervous, and many of us very nervous ever since. What does it really mean? And I think in terms of the emancipation continuum, where healthcare is our first and most important human right, air, water, food, and healthcare. Have you noticed that since this war, all of a sudden we're hearing, oh, we're going to have a food security problem, food security. All of these problems we've been talking about food security, but we have all of these vertical farming and precision farming. Why do we need to have a food security problem? There's absolutely no reason why we have to have a food security problem, even in America. I don't care how much wheat comes from wherever, right? So the point is, why are we being fed this narrative ahead of the curve? So since food and nutrition and health go together, I think we better wake up and smell the coffee and figure out at the local elected official level, forget the federal level, because that's just too hard a thing. At the local elected officials, how do we work with our state governments, state elected officials? How do we create commissions on the future? This is my pet topic. Commissions on the future, and we can find a way to get these HBCUs and other conscious universities that want to start looking at these fault lines around which our freedoms can be curtailed in the future. And this pandemic is a big area in where our freedoms, having seen, and yes, it's true, it was very frightening, all of us were frightened, right? But my point is, having learned what we learned in the last 2 years, how do we prepare to be better consumers and citizens when the next virus comes? Because we know because of climate change, the virus fear has woken up, and the virus fear is pretty pissed off right about now with the rate of extinction of the regular mosquitoes, animals, and things they used to live in. They don't have them to live in, so they're coming for us. That's my opinion. I'm not a doctor or a healthcare practitioner, but I'm an engineer. That's my engineering perspective. Somebody can tell me if I'm wrong.
Well, there's a lot of...
Go ahead, Lorraine, sorry.
But go ahead.
Oh, you have said it all. Um, I don't really have much more to say. As you say, what do you take back? We definitely want to keep the pushing on behalf of our patients to make sure that we're able to continue to see them. As Dr. Moore says, it's not just seeing the patients, it's that we're able to go beyond the patient and to also involve their family, their environment. So it becomes more holistic. So we want to make sure that we're pushing for that and that it doesn't stop. That means that we don't go back. It's not that we're going to go back to where it was, but sometimes when a good thing is going on, sometimes something comes in and curtail it to say let us curtail it a bit so that we can kind of push people back into the office. We want to be able to have our patients have the choice of, do they want to see me as a therapist in the comfort of their own home, or do they want to see a Dr. Moore in the comfort of their own home as they can? Is it possible? And if it's possible, they should be able to do that. So we want to keep that going. And add, as you said, add more innovation to that. So make it more seamless, make it more not where it's difficult for them, because I do know there's some patients that will have a difficult time finding providers. Make it that it's easy for us to be found as providers, and the accessibility is there, because we're here to provide the support.
One thing you said about that I wanted to focus on, that you brought up, and I think it's a good thing about telemedicine, is the network within telemedicine. So you're in your session with your client, you might feel that you need to do a referral to a dermatologist or such. Perhaps there's a network of practitioners that can be utilized in that manner. So I see that there is a great amount of possibilities to further explore. Let me see what's going on in the chat. Chat. Okay, Mr. Rob Smith to everyone. Would it truly be accurate to say that the vaccine had no effect on the SARS-CoV-2? You're muted.
I'm the one responsible for that statement, so I'll respond to that. I think what would be more accurate is that we have no evidence that it has had an effect. If you look at, pandemics are pretty predictable. Farr, who was an epidemiologist in the middle of the 19th century, he basically worked it all out for us. He told us that infectious diseases, particularly ones like influenza and coronaviruses, which are, they come quickly and go quickly. He saw we had all these waves. They really follow a mathematical curve, a bell curve. And if you look, you don't see, I dare anyone to show me a vaccine effect on any of those curves. We got about 5 curves in New York, about 5 curves in America. The worldwide curve is 5 or 6 different bell curves. They go sort of up and down like this. And the reason why we don't see one big curve is because different places are experiencing the pandemic, the epidemic at different times. The way it came into America, it came in the Northeast, and it came in the South, the Northwest, almost simultaneously. Then it moved down coast, then it sort of found its way into the center of the country, and by the time it got there, it started again with a second wave. And you look, it's the same all around. So, in one of these curves, you should be able to say, this is pre-vaccine, this is post-vaccine. So we don't see that. You can't show me an effect where you could go back and say, oh, this is where the vaccine started. We just didn't see a change. As a matter of fact, our biggest wave came post-vaccine. That was the Omicron wave. If you look at that curve is off the chart. They had to redo the curve so that you could get the Omicron wave on it. That was when everybody was vaccinated and people like me was already boosted.
Okay, so you're not saying no, but you're not saying, but what you're saying is you're not seeing with the curves, you're not seeing where the vaccine is pulling down. I think I saw like a two-week interval change in when they were looking at that. I'd have to go back through my notes because we were following it very closely. Actually, probably too closely, but following the curves. And when, especially New York City, when they started having their reduction, it was going in a certain algorithm per se. So that would be a very interesting concept to look at with the impact of the vaccine. So you like overlay the prevalence, and then you overlay that with the prevalence of the vaccine or the disbursement of the vaccine. So it actually, the disbursement of the vaccine should be here, and then the curve should be, prevalence should spike down, really.
You should have changed the curve. If you put an intervention, you should change the curve. Well, so what data do we have? I mean, if you want to go there, I can throw a little bit in. We have two sets of data. We have the epidemiologic data, and then we have the clinical trial data. The clinical trial data for the vaccines that were 6 months. We had 6 months of study of the vaccines. At the end of 6 months,
I was part of that, yes.
At the end of 6 months, nobody bothered to look at the effect because the pharmaceutical companies didn't make them easily available. But if you know how to find it, you can go look for it. What do you think the difference between deaths between the people who took the vaccine and didn't take the vaccine? What do you think the difference in death was? It was none, no difference. One person died in the vaccine, in the non-vaccine arm of in the placebo arm, and 0 people died in the vaccine arm. This was 40,000 people in the Pfizer trial, and similarly in the Moderna trial. We don't see any difference. So, under what basis did they say there's a difference in death if you take the vaccine? There was no difference in the trial, the clinical trial. So then you had to go look at the epidemiologic data. Mm-hmm. In the beginning, they said all the people going into the hospital were unvaccinated. Well, of course, most of the people weren't vaccinated yet. Once all the people got vaccinated, everybody who goes in the hospital now with COVID is vaccinated. That's because everybody's already vaccinated. So what I'm saying, the public, the information we were given was, they know this, Dr. Fauci knows this, but if I know it, he knows it long before me because I'm looking at the data after they release it. So you can figure it out yourself. Go back and look at the curves and look for the vaccine effect. The vaccines came in December of 2020, and
that's right.
Those vaccines somewhere between January and March, April, May. Omicron came at the end. When we should have all been. We were losing the effect of the first set of vaccines before Omicron came, and when Omicron came, many of us who got Omicron, and I got it. Because, after I took my booster, and all those elected officials, they got it too. You saw it. Even the ones who stayed away from it for the longest time, they're getting it now.
Yeah, but the vaccine was not designed to address the Omicron strain of the virus. So
why don't we? If we could have,
the initial
in 6 months to a year, 2.5 years have passed. Where is the next vaccine?
Don't worry, it's on its way.
Right after we're post-pandemic almost, so we should have had another vaccine in there a year ago.
So you're saying that during the innovation of the vaccine, they should have anticipated a mutation in the strain and prepared?
No, that's not what I'm saying. What I'm saying
No.
is the creation of these vaccines weren't created for your health. It was created to sell products. Just like how I started my initial statement that way. We practice medicine not to take care of people. We practice medicine to make money. We're running a business. We know that people are going to do fine anyway. Very little of what we do will determine the death rate doesn't change. It's always one per person. Right? It's the social determinants of health that determine our life expectancy and all these other things. Medical intervention has a very small, so why are we spending all this money on medical intervention, drugs, hospitalization, and all of these things? We spend none on the social interventions, and people make billions of dollars on COVID, yet the people suffer the disease unchanged. And also all I'm saying. That's what I'm saying. Exactly what I'm saying.
We have a few more minutes before we close, and what I would like to summarize is this, and I think it's going to be important that we look at these social determinants of health, because they affect not only they all rely on each other. Good healthy food, reduce the incidence of disease, lower the cholesterol, lower the blood pressure.
Not putting 6 people in a room, they're going to spread infectious disease.
Housing. Yep. Housing space. Yes, a little more elbow room. That came to light also. The close housing situations.
Let me also throw one thing in there I haven't said as we wrap it up. You know, we build these structures, the built environment. We lock ourselves up. We make it hermetically seal ourselves in with these germs. And as you said, if you're going out into the park, you don't have to worry about coronavirus. Well, why can't we just ventilate our spaces? You know, open the window. You know, stop building buildings where you can't open the window.
Yeah, that's very interesting. Yeah.
What happened? Why did we lock the schools in New York City? Because we couldn't open the windows.
Interesting. Well, thank you, Dr. Moore, for this thought. I'm